Hi, this is QD Video brought to you by Room Now Live, where it's not about the dots and the data, it's about connecting the dots. Imagine that. Today's case is rules for pregnancy. So I just finished seeing a 27-year-old gal who was nulliparous until recently, and she had just delivered her baby. She had a healthy young girl while taking tocilizumab. And this brings up the issue of how to manage patients with inflammatory arthritis who are on DMARDs and biologics, or those who want to get pregnant. I think the smartest thing actually I heard at last year's ACR is if you have a woman of childbearing age in your clinic, you need to have the discussion at every visit about what's your plan for getting pregnant. They need to have a plan. They need to know that you have a plan. And towards that end, the ACR is coming out with a 3-part manuscript on guidelines for patients with rheumatic disease and their reproductive health. It's going to talk about contraception, lactation, the use of drugs. It's going to cover all rheumatic diseases, inflammatory disease, lupus, etc. So look for that. It's going to be voluminous. It's going to be really instructive. There should be a lot of education around it. And you can develop your own rules based on that guideline when it comes out. But let me give you my guideline for what happens. What's interesting about this patient is she was told by the many doctors that saw her before me when she had a febrile undiagnosed disease, when she was diagnosed with Still's disease, and she had, spiking fevers to 105, evanescent rashes, polyarthritis, serositis, lymphadenopathy, splenomegaly, the whole, package. When she was diagnosed, they told her, never get pregnant. You may not ever get pregnant. That it would be dangerous to get pregnant. And of course, all that's just goofy and wrong. So that's the first thing I told her when I saw her. And she was on methotrexate, and I put her on a biologic. In this case, we put her on tocilizumab. She did really well. She stopped her methotrexate, was doing very well on tocilizumab. And she asked, now can I get pregnant? And I told her, of course, you have to be off methotrexate to consider that. And now she was doing great. She was in remission. And I said, absolutely, get pregnant. Let's see what happens, and we'll manage it after that. Soon after got pregnant, stayed on the drug. She stopped the drug for about 3 or 4 weeks around the time that she was delivering, and she resumed the drug after delivery and is now breastfeeding on the drug. So here are the rules. Number 1, you need to be and this applies to people with an RA, psoriatic arthritis, inflammatory arthritis. These are not necessarily rules for other autoimmune diseases like lupus. Number 1, you need to be in remission to get pregnant. When you're in remission and you've been in remission for a while, you're safe to get pregnant. It's going to have the best outcome. You have to have a healthy mama to make a healthy baby. Number 2, if you're not quite in remission and you're low disease activity, you need to be on some therapy to get pregnant. So, and of course, you should be on therapy that's compatible with pregnancy. You should not be on leflunomide, mycophenolate, and methotrexate. Of those 3, the most dangerous phytotoxic drug is mycophenolate, not methotrexate. So yes, you can switch over to any other DMARD or biologic. Preferred biologics to get pregnant on, if you're going to want to get pregnant, would be first certolizumab and 2 etanercept, mainly because they have a short half-life, and I can manipulate those much better. I think all other biologics, like my patient on Actemra, are fine. There's growing amounts of data suggest that you can conceive on those medicines and can take them throughout pregnancy. Remember, there's a big wide area, or a big voluminous area of research from the GI world where Crohn's and UC patients actually have a lot of flares during pregnancy, so they need to be managed, and they stay on these biologics almost uniformly, often with DMARDs and 6-MP and other therapies, and they do very, very well. So you can stay on another biologic. I don't want to be pushing being on either rituximab or a JAK inhibitor, rituximab because it's long half-life, JAK inhibitor because I don't think we have enough evidence yet. But you can be on any one, get pregnant, and if you're in remission at the time you are beta HCG positive and you have already conceived, and you're in remission and doing well, you can stop the biologic. If you're not in remission, you should continue it throughout the pregnancy. So what do you do during the pregnancy? Just continue it, and you can continue throughout. Again, based on how well they're doing, you could stop it midway through or at the last trimester if they're sailing through. But many people can safely take that. Again, roughly about 20% of rheumatoids might need to be on a biologic, although I think that more than that percentage are actually going to have activity during pregnancy. Again, the issue really here is the mother. If this is their first pregnancy, they're hell-bent on being off of all drugs. If this is their fourth pregnancy, they're like, give me all the drugs you need. I know I can make a baby. So, so if they get if they're going to deliver, you could stop. And basically the rules there on stopping a biologic that they're on, they're going to deliver, is you don't want them to have peak drug levels of that drug at the time of delivery. You want to minimize any risk of infection. So if they're on an infusible like infliximab, you wouldn't do an infliximab infusion and deliver on the next day or Tuesday. You'd want to wait till 6 or 8 weeks later. Same thing for adalimumab or any other injectable that has a longer half-life. You want to be maybe off for a week or two, or as long as you can, and then you can resume it soon after they're at home and the baby's breastfeeding. You can resume it right away. If you think the patient needed it during pregnancy, they're probably going to need it postpartum. I wanted to make a statement about what to do during the pregnancy while they're still pregnant. After 8 weeks, certainly after 12 weeks of pregnancy, you can use any drug you want. You can use fetotoxic drugs, you can use cyclophosphamide, you can use chemotherapy, you can use Coumadin, colchicine, you name it, any drug almost, because the baby's already made. Organogenesis is done. You might want to change some things, certainly no nonsteroidals in the last 6 weeks or so before delivery, because that has issues with the patent ductus arteriosus that can prematurely close under the influence of prostaglandin inhibition. But other than that, you can use almost any drug in the second and third trimester of drug. I've had patients recently with complex disorders who are taking multiple drugs, a DMARD, I think one patient was on 2 DMARDs, and taking abatacept at the same time, and another one was taking, so really you can use any kind of combination at that point without any real risk. At delivery, again, you should try to be off the drug at the time of delivery, and then you can resume during breastfeeding. You can pretty much use every drug during breastfeeding. There's very little evidence that any of it gets in the breast milk, and if it does get in the breast milk, there's almost no evidence that's going to get into the child's bloodstream. So those are my rules on managing pregnancy. I hope you find them helpful, and we'll talk to you at the next QD video.